Pulmonic regurgitation, the leakage of blood from pulmonary artery into the right ventricle. This is pulmonary artery and this is right ventricle. If there is leakage of blood from pulmonary artery into the right ventricle, it is pulmonic regurgitation. Now pathophysiology. Pathophysiology is divided into acute pulmonic regurgitation or chronic pulmonic regurgitation. In case of acute pulmonic regurgitation, right ventricle have no time to adapt. This lead to the right-sided heart failure. This is the right side of heart and this is left side of heart. If there is acute regurgitation, so this right ventricle does not have enough time to adapt and there is right side heart failure. So this right side of heart won't work and don't pump the blood into the lungs. In case of chronic pulmonic regurgitation, if there is regurgitation from here, and in case of chronic it have time, volume overload means blood came back from pulmonic artery into the right ventricle and there is more volume now in this right ventricle. There would be eccentric hypertrophy. We know that there are two types of hypertrophy, either eccentric or either concentric. Concentric mean more muscle mass of heart wall, but eccentric mean it is thin but volume is more. It is spread like this. So have time, volume overload, eccentric hypertrophy goes to the right heart failure. And now come to the etiologies. Etiology mean causes. What are the causes of pulmonic regurgitation? Normally the severe pulmonic regurgitation is rare. The topic we are studying now, it's very rare topic. But the most common cause of pulmonic regurgitation is balloon valvulotomy or other intervention to treat pulmonic stenosis, right ventricular outdrag obstruction due to the teratology of Fallot. These are diseases. Suppose a patient is having pulmonic stenosis or teratology of Fallot. This is disease. In this disease, right ventricular outdrag is obstructed. This right ventricular outdrag is obstructed from here. So in order to treat these diseases, we do intervention, surgical intervention. And this surgical intervention can cause pulmonic regurgitation. It is the number one cause. It is also cause iatrogenic pulmonic regurgitation. Now the rare cases, infective endocarditis and rheumatic heart disease can also cause, but in very rare cases. Pulmonary hypertension can also cause mild pulmonary regurgitation if there is hypertension in lungs. So it can also cause backward flow of blood from this artery into the right ventricle, but it causes mild, does not cause severe case. Now pathology. On pathology and gross pathology, you will find dilated main pulmonic artery and dysmorphic wall cusp. This artery is dilated. On gross examination, this artery is dilated. So this is pathology. Now we'll go to the clinical presentation. Clinical presentation, either it could be of pulmonic regurgitation, that is acute or chronic. In case of acute, right side heart failure plus cardiogenic shock. Cardiogenic shock means there would be tachypnea and low blood pressure, etc. In case of chronic pulmonary regurgitation, either it could be symptomatic or either it could be asymptomatic. So for asymptomatic, it remains for years and years, like for 10 years, 20 years. But when there is symptom developed, the symptom are of right side heart failure. So in heart failure, we have studied that in case of right side heart failure, symptom would be hepatic congestion, lower extremity edema, dyspnea and jugular venous distension. These are the symptoms with which patient present to you in your clinic. So you do the physical examination to rule out causes. So when you do auscultation, you will find decrescendo diastolic murmur. Murmur is hard sound. It happen in diastole, not systole, and its characteristic is decrescendo. You will find it on left upper sternal border. Upper side of sternum, on left side you will find this sound, as well as this is also called pulmonic area. Best heard in chronic pulmonic regurgitation, not in acute. So it is best heard in chronic pulmonic regurgitation. You will also find S3. S3 can also be heard. What is S3? When blood strike to the eccentric hypertrophied wall, S3 may be heard, as well as right ventricular heave, that is also called parasternal heave. When you see the chest, you will find this heave. So on ECG you will find right ventricular hypertrophy. the right ventricle has been hypertrophied. Why? Because blood came back and this caused hypertrophy. There is eccentric hypertrophy. You will find that hypertrophy on ECG. On chest x-ray, there would be right ventricular enlargement. So how will you diagnose the patient? Diagnosis is basically on clinical presentation plus echocardiography. On echocardiography, you will find regurgitant jet from pulmonic artery into the right ventricle. You will find that during diastolic blood is coming back from this on echocardiography. You will also find right ventricle dilatation. This right ventricle has been dilated in case of severe pulmonic regurgitation. How will you manage the patient in case of mild or moderate or severe but no symptomatic? Mild, moderate and severe but no symptomatic, you will just say to the patient, periodical clinical evaluation, come to my clinic after either 6 month or someone else period, but periodic clinical surveillance is necessary. In case of severe pulmonic regurgitation, the definite treatment is surgical pulmonic wall replacement. You replace this wall with a new one. And if you don't do so, what could be the complication? The complication could be decompensated heart failure.